what do you love about it? And what are the drawbacks that you wish you knew back when they were at your stage? And find 3 different attendings. You can ask residents, but they really have good insight into what it's like to do a residency, and you're looking for a 30 or 40-year career. And try to get several opinions so you don't just get one outlier who's just a weird person, but ask about the fields that you're in, and treat the clerkship year as a giant differential diagnosis. You're going to rule things out as you go along. But anyway, you can certainly look through this for a moment more. It says if you're hardworking or not so much, if your attitude is you're mean or you're nice or it doesn't matter, do you like patients who are asleep or dead? Are you afraid of the light? Are you afraid of the dark? Are you a drug? So anyway, enjoy that graphic. I'm going to switch now to emergency medicine. So why emergency medicine? I'm going to answer that question so you don't have to ask me, since it'd be weird for the number of 54 of you to ask me at the same time. So what do I love about emergency medicine? And I want you to ask several different attendings when you're on these rotations these questions. So what I love about it, one is I love the variety of patients that I know myself. I have what is known now as ADD. They had different names for when I was a kid. They weren't quite as supportive, but I get bored doing the same thing over and over again. I can't sew up, lap choles and appendicitis every day, or even do cardiac bypass surgery every day over and over again. I get bored too easily. So I love that I pick up one chart in the pediatrician. I pick up another chart and I'm an orthopedist. I pick up another chart. I'm a cardiologist. I pick up the next chart and I'm an OB. Then I pick up another chart, and et cetera, et cetera. I love that variety of my days are never the same 2 days in a row. That's me. I'm ADD. I'm the one who can't sit still. If you were like me, most of you, I could see your little videos bobbing up and down because you have that ER doctor leg going that you just can't quiet. Nobody wants to sit next to you in a movie theater because of that. Then you're an ER doctor. So no attention span at all. I love the variety. I get bored too easily. I love that I get to use my head and my hands in a specialty. So I love the Sherlock Holmes clue gathering of the differential diagnosis and trying to figure out what history and the physical exam and the test, what is going on, how to explain it. So cool. I got the answer, and I love solving that puzzle. But I also really like using my hands, and I don't want to give up procedures. And I can sew up a face that's ripped off by dogs, or crack open someone's chest and manually restart their heart with my hands. And clearly that doesn't happen too often. But at the same time, using both my head and my hands is really helpful. I love the immediate gratification of you have someone who's scared and they just met you, and you have to convince them sometimes to literally put their life in your hands, and you do something and you make them better in front of your eyes. I love that immediate gratification. I can move on to the next patient. And that's me. I just don't have the attention span. Squirrel, I don't have the attention span. So if you have that ER doctor leg and you're, just have a short attention span, that ADD, think of, I want someone to get better. I don't want to manage them for months and years and maybe feel like I'm not making a lot of progress. So that's who I am in my attention span. These are my personality, and that may resonate with you, like not, as you talk to clerkship directors from each of your specialties. And I like to feel like I'm going to make a difference. I like that I work in a safety net hospital. I love my patient population. The thank yous are genuine. I really feel like I'm making a difference so people have nowhere else to go, and they're willing to trust just one more doctor, something as important as their healthcare. It's amazingly gratifying. So I love that I feel like I can make a difference. So the drawbacks, to be honest, I've heard a lot of drawbacks of emergency medicine, and this is going to be my perspective. Most of the drawbacks I heard are actually strengths. And the one strength that I always hear is actually a drawback. So the drawbacks I hear, one is that the burnout is really high in emergency medicine. Those studies were done on across all people doing emergency medicine back when it was unusual to have an emergency medicine residency trained board certified doctor practicing in EM. And even today, 50% of EDs in the country have don't have a single EM trained board certified doc working in it. They're mostly family medicine, internal medicine. And yes, that's stressful. If you don't know if you're internal medicine and you never learn how to take care of a baby, that's stressful, lead to burnout. If you're a family medicine doctor and you don't know how to take care of an MVC, that's stressful. So the burnout's higher. When they repeated those studies with EM residency trained board certified doctors, the burnout rate's the same as every other specialty. Another downside I hear is there's a lot of primary care in emergency medicine. That's very true. And it's part of the variety of what I love about emergency medicine. I can't just take care of heart attacks and gunshot wounds and strokes all day long. I love the variety. I love that I take care of someone's having a STEMI, and then I get to go teach somebody about a diabetic diet. And then I take care of someone who was just shot in the chest. And then my next patient, I have to teach them about their high blood pressure medicines and why it's important to take those even on days they're feeling great. And then I go on and I have a patient who's having an acute stroke. So I love the variety, including the variety of taking care of primary care. I would get fired really quickly if I just take care of these high acuity patients, every patient all day So that is no difference. The other thing I hear about as a negative is that you don't have the long-term relationships that you have with your patients if you're in a family medicine or another primary care specialty. And that's true. And I'm a people person. I love people. I love my patients. I love hearing about their grandchildren. I love hearing about what they did for a living. And I thought that would be a real problem for me. But I find the intensity of the relationships that I have with my patients in emergency medicine is so amazing and so great that, you know, like I said, you have someone who literally just met you and you have to convince them within a few seconds to trust you and put their life in your hands. Or you just have to hold their hand and listen to their story because all they really want to do is know someone cared and they actually are fairly healthy. They were just worried about something. It's so intensely gratifying. The emotional highs are so high, the lows are low. But I find that the relationships with my patients are so intense and so rewarding that I don't go home feeling like I didn't have a gratifying patient interaction during the day. So while I was worried about that, especially with who I am, I'm actually very happy with my relationship with my patients. The one downside I hear is, the one downside to me of the field is the thing it's always had as an upside, which is the schedule. The ED is always open. It's open now on a Saturday. It's open at night. It's open on the weekends. It's open on holidays. So you will be driving to work while your friends are coming home to watch their kids play soccer, right? You'll be driving to work when your friends are putting their kids to bed. And you'll be driving to work when their friends are having their kids open their kids' Christmas presents. And you will also have probably a very non-circadian schedule because my scheduler sucks and most people's schedulers suck. And you will go from night shift straight into day shift, straight into evening shifts, back to night shift, back to day shift, back to night shift, back to evening shift. And that's really hard to do. And as the decades go on and you get more gray in your hair or less hair like me, you will struggle with that more and more. And, you know, finding a practice which has at least some of that seniority scheduling built in is hard to find, and it's a little more rare each time. So I'm just moving your faces around so I can see my screen and see at least 3 or 4 of you nodding, so I know that you can actually hear my audio. Anyway, so that's the upsides and downsides. So ask your attendings as you go through your specialties, what do you love about the field? Why did you choose it? What are the drawbacks? And ask 3 or 4 attendings. So that's my M1 and M2 talk. So what do I do? What's my secret sauce? And I teased Tori this morning about giving away all our secrets, so I'm going to do the same thing. So what do I do when I look at an application? This is the order I look in. This is the priority that I look into your applications. And I teach my associate program directors and my assistant program directors that the order that we look for is 1, good ED doc. 2, good person. 3rd, least important, good academics. And I think that most of us use a holistic approach to application season. I don't see that changing a huge amount this year, even though we have a little bit less data that's really important. But the first thing I want to know is, are you a good ED doc? And that's your SLOs. So I'm going to spend a lot of time talking about that because it's such an important part of getting into residency and getting that interview. Your letters of recommendation, your SLOs, based in EM residency-based rotations. I'll talk about that in a little bit. The next thing I do is just for screening's sake, I'll look at if your SLOs are good and they're at the level that I'm looking for and they're EM residency-based SLOs, then I want to see, are your academics okay? So I look at your dean's letter, see if you're in the top half of your medical school class, see if you got honors in your clerkships or any of your clerkships, see if you have any professionalisms or interpersonal communication skills that's used in your dean's letter. And I look at your board scores. I may look at your board scores just to say, all right, are you going to be in the remediation hole for 3 years for your in-training exam score? And are you going to pass the boards in the written on the first try when you graduate, you pass your written boards? And that's the only reason why I look. And if I think you are, I'm done with your board scores. I don't think that a 235 is any different than a 255 in my head. I do think that's different from a 205. I don't think it's any different from a 275, although some of those people are both fucked up. So it's worth looking at their application a little closer. It's a really high score. But at the same time, I'm looking at it as a screen yes or no thing. We do not use a cutoff here in Austin, even though we are a pretty competitive program based on geography. It's not me. I know people don't come here just because of me. I wish they did. Humor me. I know we're here in Austin. We get a lot of applications, but we don't use this cutoff score. There are programs that do. If you're below that cutoff, you don't have any control over it anyway. Just focus your effort on the places where you are getting your interviews and don't fret about places where you're not. But that's all we use academics for. CV, this is going to vary from program to program. I'm going to talk about each of these elements in detail, but we're looking for common values with, what are our program's values? What values do I see showing through on your CV? And are your values the same as ours? Are we a big research program? Or are you a big researcher? Are we a big public advocacy community service firm? That's us, by the way. Do you have a track record of leadership and involvement in that area? All of you guys are part of TCEP side. Are you big into global health? Are you big into EMS? We're looking for what your values are, and do they line up with our values, our program's values, or do they line up with a value that we don't necessarily have, but we'd like to grow into, and maybe you'd be able to help us with that. And your personal statement, we look to mainly see if you're crazy, and personal statements are helpful for that. And if you can complete a sentence with grammar, that's always a nice plus. And also, if you thought about why you want to do emergency medicine, you have mature decision-making around that process. And then when you get to the interview, we're really looking for fit. You've passed all of these steps. Now we're looking for, do you fit in with our program's culture and our residents? And that's our secret sauce. So I'm going to take through a lot of this, but I'm going to spend most of the time talking about SLOs. So what is a SLO? SLO is a standardized letter of evaluation. And that letter is it's basically a letter recommendation from EM faculty. It's an EM specific thing, although orthopedics has finally started adopting this about a year or two ago, just stole it right from us, which is good. And if you look at other specialties, if you ask them to produce the last slide I showed you, letters of recommendation are on the bottom because they don't tell you anything. So standard letter of evaluation is really helpful. It'll be what you get after you complete your any rotation in emergency medicine, or when you interact with the EM faculty, you ask them for a letter. They're supposed to complete it in the standardized format. How do you get them? You're going to do a rotation, and I'll pitch EM residency-based places, and you will then ask if they do a formal composite evaluation. A lot of programs, a lot of rotations, the clerkship director or the educational leadership get together at the end of the month, put together all your faculty evaluations, and write a composite letter based on all those different opinions. Or you'll get individual letters from people. And it's something most places will do that automatically. You should ask them anyway. So clerkship director, I'm having a great month here. I love a letter from this rotation. Do you guys do a composite letter? May I have one? And ask anyway. Don't just assume, or else you might leave without a letter. It is important that you get letters from emergency medicine, and especially emergency medicine residency-based rotations. And the reason why I keep spouting that is because the community-based rotations letters don't really have as much weight with me, because I'm looking for someone who's trained a lot of students, trained a lot of residents, and then with retrospect knows which characteristics in a student turned out when they matched that person to be a good resident, which ones didn't. So if someone says that this person is going to be a great resident, that makes sense to me because they've had a lot of experience. If they're community-based rotation, and they've never trained a resident before, and they say that you're a great student, it's kind of like your mom writing you a letter and saying you're a nice person, which is good. It's nice that we like nice people, but it doesn't tell me from insight that this person is going to make a great resident, because we've trained a lot of residents, and the student reminds me of the ones who turned out to be great residents when we matched them. How many do you need? Well, this is a really unusual year, and I'm going to try to speak in general because it's a broad audience. But in general, places want 2 letters, one from your home rotation if you have a home program, and then one is an away. And I'll talk about how to pick out those rotations. This is a different year. I promise I have a whole slide dedicated to COVID, so I'll spend a lot of time talking about this. But this year we are expecting 1 EM SLO, and I can talk to you about where you might get other SLOs from. But if you're worried, oh my God, I have 1 SLO, everyone's in the same boat, or practically everyone's in the same boat. Do not spend time worrying about things that you can't control in your life. You'll be fine. Everyone has the same 1 SLO. So let's look at this for a second, work backwards on how many letters we need. So this is for a normal year, and the first thing you can notice is I forgot to flip the calendar over, which is awesome. It's nice to have a really big audience of 69 people see you make a mistake like that. So on a normal year, EROS opens on September 15th. Now this year it's October 21st, so everything I say right now push back 1 month. So most programs, and I surveyed them, most programs, and when I say most, I mean a third, want their application deadline, the application is complete for them to start cutting on October 1st, or about October 1st. So you want your application complete by October 1st. A third of the programs said, when I surveyed them, October 1. A third of the programs said October 15th in a normal year. This was last year's survey. And a third of the programs were all over the map. So it's a good, safe way to say, I want to shoot for my application to be complete by October 1. Now, you have control over a lot of that. You do not have control over the SLOs, and that's the thing that's going to tie you up the longest. So how do I get my SLOs in on time? Well, first off, it takes about a month after your rotation's over for us to write you a slug. So first thing that happens is you complete your month, you do awesome, and then the clerkship director compiles all the faculty evaluations and resident evaluations, puts them together on some sort of a bell curve. It takes about 2 weeks to get all the faculty evaluations back. Then it takes a week for him to put it on a bell curve and decide what your grade is. And then he sends it to me, and then I find out I spent about a week looking for a hole in my schedule to go write you that slow. So it takes about a month after your rotation's over. So if we're working backwards, and October 1 is my deadline for trying to get my application complete before programs start hitting the invite or reject button, then what I'm really looking at is doing, I don't know why I did that twice. So I'm gonna use September 30th. Use September 30th as your real deadline. Is doing a rotation in June or July or August, so that the letter writer has that month to write your letter and get it into your ARIS file so that it gets looked at by that September 30, October 1 deadline. You might be able to go with September as well. In general, the clerkship directors know that the turnaround for that month just has to be tight, and they have to really just be on their game. Most of them now know that they have to just work really hard that month to get it done. As soon as you leave, they're badgering faculty and trying to clear out their calendar, right? That last block of slows. Some of them don't get them done on time, so it's a little bit more chancy to do your EM rotations in September. After that, your rotations still are important. They won't get you an interview because I won't see your letters by them. So if you have a rotation scheduled for October or November, certainly do it and get a letter. It's a great way to see what other programs are like. But just know that that won't help to get you the interview. What will help is if you got the interview based on the rest of your application, when we actually interview you and we rank you that day, we'll look at your file and we'll see, oh, there's a new letter, and that'll help with your ranking, and we'll look for more letters after that too. But no, it won't get you the interview. So you really want to try to do your rotations in June, July, and August, especially at home rotation as early as you can. So when does VSAS open? VSAS is a visiting student application service for doing your rotations. There's some variation here. Most schools open on April 1. Some do it in March, some do it in May. But you want to have your list of programs that you're going to apply to by April. I always recommend that you start with your home rotation if you have a home rotation. If not, you're going to have to do 2 EM rotations away. But you'll want to start with your home rotation. And the reason for that is, one is your slows tend to be a little bit better from your home rotation. There's a home field advantage. We probably know you for 3 or 4 years already. We tend to sort of be invested in your success. So unfortunately, and we're worried about that this year because everyone's going to have only a home rotation, that everyone tends to kind of let her inflate a little bit on our home rotations. Plus, it's a good opportunity for you to get your foundational skills down really, really well. So when you go do an away rotation, afterwards, you'll perform well and you'll get a better slow, and you'll also audition better for that residency. So home rotation first is a really, really good plan. If you don't have a home rotation, clearly you're just going to do an away rotation here to start off with. And I like to do that as early as possible. If your school allows you to do it in June, you get it done in June before the mad rush of everyone trying to do them in July, August, and September starts. And then you're going to do your away rotation afterwards. And how you pick out your away rotation is challenging. And I should let you know that there are actually programs outside of Texas. I know it's shocking. Why would that happen? But there are 11 civilian programs in Texas. So you might consider doing an away rotation outside of Texas. So there's a lot of states in this country. I know that Texans in general are aware that there are other states, but you don't really know why. You should just be aware that you might actually do a rotation out of Texas, and there's some advantages to that. Who switched my slide? Hey, Texans. Anyway, I'll talk about why you should do that in the next slide. So how do you pick out where you want to do a rotation? Is a challenge. And the best way to pick out where you're going to do your audition rotations, and also, quite frankly, the best way to pick out a residency, is to really sit down and think about what your learning style is. Now, some of you guys learn really well, and there's a continuum out there, and I'm going to give you 2 cartoonish extremes just to explain what I mean by this. But some of you guys really learn well in a very county type environment, very resident run ED. It's really busy. There's tons of patients up to your eyeballs. There's blood in your hair at the end of your shift. The attending's in the next state. You're trying to present to them, and you're on your own. Sorry. But there's advantages to that. There's a great pathology of the knife and gun club. There is the autonomy of you owning your patients and trying to figure out what the mystery is and solving it and getting them better and admitting them or discharging them. So there's advantages to that. And the other extreme is the sort of small community powder puff place where you see a patient, and you present to the attending, and you go back and do a lit search, and then you print out copies of the articles for everybody, sit around in a circle holding hands, saying kumbaya and discussing the article. And there's advantages to that too. There's more one-on-one teaching, there's more small group learning. Your friends meet at Thursdays in Starbucks to go over Rosh review, since that was plugged so heavily this morning. I like peer questions better, by the way. So there's advantage. And what is your learning style? And I would postulate that some of you think you know what your learning style is. You might think you're like county, for example. And I would encourage you to then pick a away rotation that's the complete opposite of your homeschools rotation, and really learn about yourself, what your learning style is, because that's where you're going to thrive in residency and do well. I remember I had a student a couple of years back who loved county. I was back at Grady at the time. Loved county, only want to be at county hospital. County. I'm like, fine, I got it. Humor me. And she went away, did a rotation at a smaller community-based place, and she came back. I had no idea. I loved it. I felt like I thrived like a learner in a way I never thought I would before. And she applied and matched a place like that. And as much as I hated to lose her, I was really glad that she picked a place where I knew she'd do really well. So my suggestion is to try to do an away rotation, the opposite of your home program on this continuum. And every place this is a continuum. There's no one at these cartoonish extremes, but try to explore what your learning style is with your auditions, because you make you more informed when you're trying to pick out a residency, and pick out your residency the same way. I know from post-NRP match statistics that geography is your #1 driver. And I know that Texans never leave Texas. I mean, it's well known. Californians never leave California. Texans never leave Texas. It's the only 2 states like that. There are only 11 civilian programs in Texas right now. And I'm never going to tell any of you, no matter how competitive you are, that you should only apply to 11 programs. I'll talk about numbers in a little while. But what you should do is understand that if you're going to apply out of state, and you'll have to, that they'll read your application knowing Texans never leave Texas, and say, oh, I don't want to waste an interview slot on this person because they're not going to come here anyway. I'd rather meet someone who's going to come here. And Texas and California never leave. And the way to counter that is to show them that you have a connection to the place. If you have family or some other reason why you can be there, that's nice. Most of us don't have that. And therefore, a way to show them that you'd be interested is to do a rotation out of state. In North Carolina, they're reading PD's reading your application saying, oh, it's another person from Texas, their application looks great, but I don't want to waste my interview slot on it. Oh, wait, here's a letter from Ohio. Maybe they are serious about leaving the state to go train. Maybe I will go interview them. So it's another way to consider as you're doing. You don't have to do that. Most people don't. But I'd say if you have to choose, I'd just try to go someplace that's opposite your style. But understand that perception is out there with workshop directors and program directors. And it's an audition rotation. So you're going to go and you're going to basically audition, and it's a 2-way interview. It's basically you're deciding if you want to be at that program. It's a good fit for you, and we want to decide if we want you. There are a lot of people who have, in general, half of residency classes are from the residents rotated with the program. And when you see that, that's a good sign. If you don't see that, it's a bad sign. It means the rotation was terrible. So we like it that half or more of every one of our classes rotated with us, because even though we don't necessarily rank that way, it means that people really love the experience and want to come with us. So you're going to audition, we're going to audition you too. So there might be a person who has a paper application that might be a little borderline, but we met them, we love them, we want them to be with us, and we're sure of it now. It's a double-edged sword. You might have an amazing paper application and go there and we're like, oh my God, who raised this person? So it could hurt you too, but at the same time, know that this is the way you're going to explore your favorite choices, and this is the way that you're going to make an impression, hopefully good, possibly bad. So that's another way that you can pick out which rotation you want to do as an away rotation. There are a lot of listings for this. VSAS, which is the application service, has a list through AMC. SAEM has their own catalog if you look at the clerk's directory catalog. And EMRA has their own one as well, and Quarter is trying to build one too, because everyone wants to have a list. I would take these with a grain of salt, because it's really hard to update these. They tend to get out of date really fast, and it's a real nightmare for me on my end to update these. The IT support and these are terrible, and it usually takes like a week for me to update each one. What I'd use it for is primarily just as a directory, so you know what programs there are. And what's nice is it's a geographical directory. So if you have preferences for where you want to train in the country and where you want to do rotations, it'll list all the programs in Texas, it'll list all the programs in the South, wherever you want to be. So that's nice, but then just use the links to the program websites, because it's much easier for programs to keep those currently. What I want to steer you away from are anything that's not on this list for a list of recommended programs. Doximity is an example that pops into my head. That is a pay-for-play program ranking, where if you give them money, they will rank your program higher. And that's how it works from our end. So when you go look at Doximity, say, hey, it actually ranks the quality of the programs 1 to 240. That's amazing. It's who's willing to bribe it. So if you look at Student Doctor Network and I would say that when people use Reddit, and you guys know this already, people who log on to that usually have an axe to grind. The silent majority tends not to go there. And I take that with a big grain of salt. Obviously, you don't believe any of it, but at the same time, you all read it. I don't really know why. If you want to get an opinion about programs, ask the people of the class ahead of you who went to emergency medicine, what was this program like on interview trail? Did any of you rotate there? And you'll get a much more accurate impression because you know the person and you know their personalities and what they're like. But use these as the only formal sources of directory information only, and links to websites. So how many applications should you send? So away rotations are just as competitive. Well, not just as competitive. They're fairly competitive to get into. So my recommendation is to find out which months you're planning to do a EM rotation and send 3 to 4 applications per block. So apply to 3 or 4 programs for audition rotations for each of these months. They can be the same 3 to 4 programs over, in June, July, August, and September. That's okay, and see what you get into. But just know it's competitive and you don't want to get locked out because you only apply to one place per block and it was a different place. You should rank in your head where you want to go of those so that if you applied in July, you hear back from your 3rd choice program out of 4 and you're like, awesome, accept. 2 weeks later, you hear back from your 1st choice, accept that one, and immediately write back to the email back to the your other program where you accepted it and said, hey, I had a scheduling conflict come up. I'm still really interested in your program, but I want to make this spot available to another student as soon as possible. Some of you are nervous about that. I will never hear about that if you do that. The clerkship director will not come to me and say that someone was not interested, someone withdrew and they must not be interested. I would interpret that way. I understand how this works. Everyone understands how this works. That is normal behavior, and that is you looking out for your student colleagues. I like that. What I will hear about is if instead of that you withdraw super last minute, like in the last 2 weeks before the rotation starts, making it very hard for me to give that spot to somebody else who desperately is waiting at home for it, or you just simply no-show. Those I will hear about, and those I will look at your application skeptically and ask for afterwards. So it's normal for you to apply to more than one place. It's normal for you to turn places down. I don't interpret that as you liking or not liking my program, so long as you give us enough notice, meaning immediately, the same day that you accepted a different rotation, that you reach out to the clerkship director and let them know that you're going to be withdrawing your application so we can fill it again. It's weird, it's so silent. I just see head nods and stuff like that. Anyway, I'm counting on you guys. So what is a SLO? This is not a secret. You can go to coreem.org and just pull up the actual SLO and see what it looks like. But I want to demystify it for you so it's not this sort of boogeyman out there. So this is the first page of the SLO. It says your name, and more importantly, it says, whoa, that was not what I wanted to happen. It says, what's the letter writer's institution? So I want to know, are you an EM residency-based place, or are you community letter writing the mom letter? This is a nice person. I've never trained a resident before. I don't know what I'm talking about. So I want an insightful letter, someone who understands what it's like to train residents. And then who's the reference provided by? In my next slide, we'll talk about how I rank these letters, but I'm looking for someone who has a lot of experience training students and residents. So they know that this student, when I've matched them in the past, made a great resident, the student reminds me of that person. So that's going to be that composite letter where the clerkship director compiles all the faculty evaluations, resident evaluations, may or may not get together to co-author with the other members of the educational leadership, and writes a composite based on your entire month, whether you work with that actual author or not. After that, I'm looking at people who are heavily involved in education. I'll talk about that, like I said, in the next slide. So what it says here on the SLO is it tells me your grade, which is awesome. And it tells me what percentage of people got honors or high pass or pass last year. So if you got honors and 70% of the people last year got honors, that doesn't really tell me very much about you at all. On the other hand, if you got a high pass and 10% got honors and 10% got high pass last year, that still means that you're a very competitive program. So what this does is it maintains transparency and accountability, so programs can't grade inflate without us seeing it, and it kind of discouraged grade inflation. The next page of the SLO has a bunch of check boxes, which I don't put a lot of weight into. And some people do parse them out, especially the ones that are personality that are harder to teach stuff like work ethic and ability to interact with others. I might look at this, but I'm really looking at it. Commitment to EM. Some people have decided that just because you discovered emergency medicine in your last rotation of your 3rd year, that you're somehow less committed to the field. I think that's a bunch of hooey. I'm glad you discovered us. I don't put any weight in this box at all. What I'm looking for in these boxes is really just make sure you're not in this last column over here. There's no accountability to these boxes. This box is accountability, and this is gold. And this is why it's the first thing I look at when I get your application is I pop open your slow, flip to the second page, I look at this box. Are you top 10%? Or are you top 1/3, mid 1/3, or lower 1/3? And then this is the accountability piece. How many letters did you write last year? And how many people did you put in those categories last year? So if I say you're top 10%, I wrote 10 letters last year, and 10 of my letters were top 10%. It doesn't tell you very much about, it tells you a lot about me, but it doesn't tell you very much about the student. If I wrote 10 letters last year, only one of them was top 10%, that's you're pretty special, and we need to look at you pretty closely. So I want to see this. This is what keeps these letters accountable, and this is what makes all the other specialty letters fairly useless. It took us about 6 or 8 years to get EM to actually be accountable, where we're like, we're not going to pay attention to your letter if you're doing a lot of letter inflation. So this is why I don't think the OSLOs are going to be particularly helpful. Specialties are new to it. They don't have any letter writing history from the year before, so they can just all mark the top 10% box without any kind of issue. And so I'm not really putting more weight into them than I do in other years. And this is kind of my tiebreaker box. You might not look so great on paper, but boy, you really are spectacular, fit for emergency medicine or vice versa. And then the last page of the narrative is this long, the letter is this long narrative form where I can describe you at length, just like I would in any other narrative letter. So that's in there too. And then the last bit is whether or not you're signing your FERPA waiver. So FERPA says that you are allowed to see your letter. And then when you request a letter, you tell the letter writer if you're going to waive that. I'm not recommending that you should or shouldn't do that, but know that most people do waive that right to see the letter, and that we as letter readers take letters more seriously if they've been waived, because we're wondering how honest someone can be if in your letter if that right is not waived. This is the letter writing. This is in general the letter writing that everyone uses around the country. Some people say, if you got two slows from the same institution, that's going to create some confusion. We don't know which one to believe. That's a bunch of hooey. The composite letter is the letter that we put the most weight on. If two letters disagree, we're going to go to this list. So composite letters worth the most, followed by individual letters from individual faculty members that are just based on their shifts that they work with you, starting with educational leadership. So program director, assistant program director, clerkship director, assistant clerkship director, all those have the same weight. After that, a letter from a titled faculty member is going to count. Next on this list, the chair, the vice chair, director EMS, director ultrasound. Just know that the chair usually only works 2 or 4 shifts a month, so they probably don't have a lot of experience. I'm going to give the clerkship director a lot more weight to their letters than I will a chair. After that, an individual slow from all EM residency-based letters from someone who doesn't have a tie up with their faculty at an EM residency. Then I'm going to put in that rank of the slows. I forget which letter they are. I know they're not O slows or E slows, so much slow. From EM related rotation, your toxicology, your ultrasound. Honestly, I'm not going to put a huge amount of weight in those. I know you guys all love ultrasound. You're all a bunch of Jello files, and having a letter saying your Jello file doesn't separate you from anybody else. If you do want to get a letter from that, because especially this year when you can't get letters from other places, ask the rotation director, hey, can I work a couple of shifts with you? Can I shadow? I know it's an ultrasound rotation, but I'm off on the weekends. I'm off at night. When are you working? Do you mind if I shadow you, so that when they write your non-EM, EM related slow about ultrasound or tox, they're also going to talk about some of your clinical skills on shift. So that's a good way to work with that as well. After that, a narrative letter from an EM rotation is going to, there's no accountability step. They don't have to check a box that says your top 1/3 and show me what they did last year. So I probably may or may not skim that. A slow or a letter from a non-EM residency-based place is going to be way down the list, because again, they've never trained a resident, so they don't know what qualities in a student makes a good resident. They can just say you're a nice person. It's a mom letter. And a letter from a non-EM specialty, to be honest with you, I don't read those anymore. Last time I think I read one was in 2006, when I decided after 6 years of reading them that they never answered the one question every piece of paper in your application, your S application needs to answer for me, which is interview or not interview. Everything is interview or not interview. And having read lots of surgeon letters and medicine letters and family practice letters and research director letters, they never once helped answer that question, so I stopped reading them. And I don't see how the OSLO is going to change that. It's still a letter writer. I mean, they're all the same. They all fill with superlatives. Half the time the pronouns don't match from paragraph to paragraph. They just downloaded from the hard drive and filled in your name at top. That's why every other specialty puts letters at the bottom, because they don't tell you anything, and they certainly don't tell you interview or not interview. Every student is the best student they've ever worked with. Even the surgeons write really nice letters for students. I don't read them anymore. I don't notice how the OSLO is going to help, because that letter writing history is going to be zeros, because they didn't ever wrote a slow last year, and they all grade inflate. So that's the order that I read letters in, and this is why you need to get that EM slow even this year from COVID, even though I know you probably only have one letter. Everyone's in the same boat that way. So I had to ask, am I really that intimidating? Keela, was I that intimidating when you guys were asking me for slows? I mean, oh my God. I like to think of myself not like this when you're asking me for slow. I think of the benign, helpful, supportive, benevolent. This is who I am when geez, goodness. Oh my God. Anyway, so the best way to ask for a slow is, hey, that was a great shift, or a bunch of shifts that we worked together. Know that, by the way, hey, thanks. Know that, by the way, you will probably only work 1 or 2 shifts with the person who's writing a letter. After 2 shifts, I mean, we're ER doctors. We make really quick impressions on our patients and diagnose them. We should be able to do the same thing with you. 2 shifts is normal. 1 shift is a little tight. You don't need 4 shifts with somebody. So you ask somebody, hey, that was a great shift or a great pair of shifts, or I felt like I learned a lot. That was really wonderful. I need a letter recommendation. Do you think you can write me a strong one? Write that down. That's the way you should ask. Do you think you can write me a strong letter? And then give them room to back out. And the reason why I say that is because my credibility as a letter writer is far more important than any one individual letter that I write. So if I write a letter, a recommendation, and Tori reads it up in Temple, and she said, wow, the student's amazing, we're going to match them, and they match them in a disaster. The next 10 letters I write the following year, do you think she's going to interview any of those people? So my letter writing is, so if I'm trying to back out of it, hey, we've only worked 12 shifts together, I don't feel like I know you. Is there anyone that you feel that got to know you better than that? Just thank them, let them back out. Don't keep pushing it, because if you push, I'm going to write the letter for you because you keep asking me to do it. But it's going to be reflective of my experiences with you. So give them room to back out. I need a letter recommendation. Do you think you can write me a strong one? And that's a good way to ask. How do you get a good slow? So I talked about this morning. Work hard. Your patients deserve that. There's an adage in emergency medicine that says if you're not 10 minutes early, you're late. Don't leave when your shift ends. Leave when your patients are taken care of. No one likes a clock watcher. At the same time, know that we're really good at what we do. We are 12 months a year. We are talent scouts. We look for talent. You don't have to say, hey, Dr. Berger, I'm here 2 hours late. Just take care of a patient. Just want to make sure you know. We know that. We notice that. So just take care of your patients. Make sure they're tucked in well before they think about going home. Own your patients. And she talked about this morning too. She did a great talk on this in more detail than I want to do on my one slide. But don't try to impress me with how many H&Ps you can do during a shift. I'm the one who's first noticing that the labs are coming back, or that the consultant put their note on a chart, or that the CAT scan's done and read, or that the patient's still in pain even though we gave them some morphine that wasn't enough or didn't work, or still throwing up. Make sure you own your patients. You're coming back to me telling me that there's new data. Now, that doesn't mean you want to be overbearing, and that's a really hard balance for medical students who walk on rotations, which is, I want to show that I'm interested and enthusiastic, engaged, and I don't want to be overbearing, and it's a really hard line to walk. But at the same time, don't go, hey, the white count came back as normal. Hey, the sodium's 137. Don't do that, but at the same time, come back when the labs are back or a critical result came back. And also, don't be a reporter. Use the rhyme thing. Come back with your plan. Hey, the labs are back, and this is how I interpret them, and this is what I want to do. And that's the medical student level we're looking for. But own your patients from soup to nuts. Everything's back. I think the patient can be safely discharged home using instructions. This is what I want to teach them. These are the instructions I want to give them. This is what I want them to come back for. These are scripts I want. Is that okay with you? Can I go talk to the patient? That's owning your patient. I'd rather you see less patients, own them completely, learn from your patients, than just show me that you did 20 H&Ps and you don't know anything about what's going on with your patients. Use SOAP, both kinds. And at the same time, understand your SOAP presentation. Starting with the chief complaints. Well, I'm not an internal medicine doctor. Please don't start with past medical history. That makes me crazy. The chief complaint, the story. If you can do a focused H&P, that's great. Don't do a focused H&P in the room. Gather all the information, but then come out of the room and give me a focused H&P based pertinent positives and pertinent negatives of the complaint. If you don't know how to do that, set that as a goal for this month. Hey, Dr. Berger, at the beginning of shift, I'm working on focusing my H&Ps. Objective, starting with your vital signs. You can say vital signs stable if you want. Only if you know what stable means. If the pulse is 100 and you're saying vital sign stable, I'm going to think you're a bad student. So if you don't know, just read them all off. But if you know, that's great. your focused, pertinent positive, negatives of the exam, and then your assessment. Your assessment's my favorite part of this. I never want to hear the Reader's Digest version. I always want to hear your assessment. That's your thinking. Too many students and interns, quite frankly, give me a SOP presentation, and the seniors want to give me a SPA. So I will love that assessment. That should be your clinical impression. What do you think is going on? What's your differential diagnosis? What's the worst case scenarios? How do you rule them out with your H&P, and what are you still worried about? The patient has chest pain. Of course, the first thing I think about with chest pain is ACS, but the patient's a young male with atypical presentation for ACS. They don't have any risk factors, and I did a heart score on them, and a heart score is 0, so I think we're good. Aortic dissection is the really bad one out there. But the patient doesn't have hypertension, they don't have atherosclerotic disease, all their pulses are equal to 4 extremities, and I just don't get that impression from the way they describe their chest pain that that's what's going on either. PE is something I always want to worry about, but I perk them out and they're perk negative. I think this is probably GERD. When they lie down, it's burning pain. It's worse when they lie down. It radiates to their throat. It feels better when they drink milk. It's worse about 5 minutes after they eat. Pneumonia is also my differential diagnosis. While they don't have a fever, I didn't hear anything from my physical exam. I know my stethoscope is 50% sensitive for pulmonary findings. So what I'd like to do is I'd like to give them a GI cocktail and some H2 blockers, and also get a chest x-ray just to be sure. And so your plan will be what's left on your differential H&P. So get really good at that. That's the skill level I'm looking for in M4. Don't be a dick. It's amazing that I have to say this. If the pharmaceutical rep brings a big tray of sandwiches and there's one left, don't get into it with the ED tech over who's more deserving of that last sandwich because you have to pay tuition and you're more important. Don't go into the patient's room and see the nurse is just triaging and checking the person in. Don't interrupt them to ask your questions because you're more important, or give them the impression that you're more important because someday you'll be a doctor. Don't start getting into a fight with the consultants or describing your patients as a drug seeker. And also be the physician when you're outside of the rotation too. You're never off stage. It's the Disney model: on stage and off stage. You're never off stage. When you go to Disney, no kid wants to see Mickey Mouse with their head off, smoking a cigarette. They'll be damaged for life. Same thing with you. You are never, there's an expression that says, be yourself. Unless you can be Batman, then be Batman. And that's true. Be yourself. Unless you're a physician, then you always need to be a physician. Don't be the student who goes to Zilker Park, which is our equivalent of our big city park, is where cool people go. So clearly I've never been there. And wear shoes that are pink sneakers that on one shoe says FU and the other shoe says CK. And then when I pulled her in the office the next day, just know that someone's probably going to see you. In that case, a resident. What if it was a patient? What if it was a patient you saw the day before? We thought you're a great doctor, and sees you say, "Oh my God, look at my doctor. Maybe I shouldn't fill that script." Maybe they didn't know what they were talking about. Or maybe they see you in the park and say, "Oh my God, look at their shoes." And the next day they go to hospital for something, and you're walking as their doctor. So you are never off stage. It's not fair, but you're always a physician, even when you're out in public. Same thing with interviews. I remember hearing from one of my faculty members who happened to returning from a flight at the same time that the student was landing for their interview the next day, and totally went off on the guy behind the rental counter. And then they walked in, and I was like, "Well, we've already done an interview, so you're never off stage. Don't be a dick." And meet with the educational leadership. It is weird for you to come and spend an entire month. I'm really not Darth Vader. And you guys keep doing that. It's weird for you to spend an entire month here and not do a shift with me, which isn't in your control. It's why I have assistant program directors and clerkship directors and people I trust. But also not meet with me either. Go into the office. Don't just say, "Hey, I just want to say hi and give you a face and name," and have a purpose when you meet with me. But it's same to go into the PD's office and say, "I want advice in your application." Something that we all have egos. We love it when you throw us at your feet for our sagely wisdom. Have some purpose, but let us actually meet you. Don't spend an entire month here and then leave. And we're sitting here, all of us, APDs, clerkship director, all sitting in a rankless meeting in February going, "Did anyone work with this? Did anyone meet with this person? Does anyone know that?" And no one does. So make sure you at least meet with someone from educational leadership, even if it's not the PD, and try to get a shift with them without screwing your fellow students over. It's a weird year. You're only going to have one EM rotation. We know that. We're going to have to deal with it. That's our problem, not your problem. We're always going to take a holistic approach to applications. I'm not going to put more weight on step scores than I did in past years or grades. I will read your application the way I always do. I'm telling my students that they should get the composite letter from their home rotation, or if you're an orphan student, from their away rotation. And then you might consider looking for one faculty member you work with a couple of shifts where you think they got to know you well, and ask them for an individual slow. Some programs don't allow that, which is kind of silly, but some of them do. And I know how to rank those two. I'll put the composite above it, but I would love a second perspective. It's not required. No one's really looking for that. No one will blackball you from having two letters from the same institution. You're going to be on video interviews. I promised Blake that I would try to keep this to an hour by not talking about interviews. This is kind of like the SVIs last year when I had to explain to people that the V is for video and that there's a camera and it turns on. So you actually have to dress professionally, pay attention to your background. It's not a good time for a drunken photo collage from college behind you. It's not a good time for you to have a shower curtain behind you, although I think it's kind of funny when that person had submitted their SVI with the shower curtain behind them. I'm like, oh yeah, I have kids. I know the only quiet place in my house is sitting on my toilet, but it might not be. You might just have to set some rules or wait till they go to bed and do your, dress professionally. This is the time to remove all your face jewelry and those giant gaskets from your ears and things like that. Let me meet the real you in July. This is a good time for me to meet the real you. It's kind of like a first date where you send your representative, you're not really yourself. Same thing for a professional job interview. And you're all in the same boat, so please don't spend any more time than you normally do freaking out about the application process. All of you have one slow, and all of you have one rotation. It's okay. We know that. That's our problem, not your problem. Your CV. So it's very easy for me to spot when you pad a CV, and I recommend that you don't. For example, research. I know from having published that the fastest I've ever published is from idea to actual publication is 2 years. So if you have 1 month of research on your CV, I know you're padding your CV. So don't pad your CV. What's important for you, and my advice, and it sounds a little bit like a fortune cookie, but what's important for you is to try to show your values on, decide be passionate about your values. Let those values show through on your CV, and you decide if your values are in line with my program. And you might not be. You can't be all things to all program. But if you love research, do tons of research. If you love community service, do a lot of community service. Get involved, and not just like I squeeze a blood pressure cuff for one afternoon. Go down to the homeless clinic and start volunteering. Become the director and do scheduling, order supplies. If you love, go join for Habitat for Humanity and build a house for somebody. If you love global health, don't just do a trip to Mexico for medical tourism for a week. Go do several trips. Make a real difference. Go dig a well or build a road. Do things that you really do, and do them in excess so that we can see what your passions are. And it's very clear to me what your values are when I read your CV. And then let me decide if my program lines up with that. And if it doesn't, it's good. If you love research, if you don't love research, but you manage to trick University of Cincinnati into thinking you're a big researcher and you match there, both of you are going to be miserable for the next 4 years. So just let your values throw on your CV and do the things you're passionate about. Don't spend a lot of time pursuing things that you're not passionate about just to pad your CV. And that's my CV advice. Your personal statement. Very few of you are good writers. We're doctors. We're terrible writers. So if you happen to be someone who's a previously published author, maybe, but most of you are not Hemingway. So for the most part, you want to stick to a fairly safe formula for this. The safe formula is start off with your big opener, which is almost always going to be I or my loved one or my best friend had some terrible injury/illness, and all was darkness around me, except for the one light radiating from the head of the bed, the eminence and compassion of the emergency doctor, and I knew I was in safe hands, and that day I wanted to be that person. You all say that, it's fine, whatever, it's good. It's a safe opening. You don't want to fall off the bell curve on this and be so out there unless you know you're a good writer. Second paragraph, why emergency medicine? This is a safe formula for writing a personal statement. I know there are a lot of reasons to go into emergency medicine. Some of them are good reasons. Some of you go into it for the wrong reasons. I want to know if you're going to the right reasons. Why emergency medicine should be spelled out. It should be somewhere in your essay, preferably fairly early on. It's weird when I read a letter which doesn't actually mention why emergency medicine or even mention emergency medicine. I remember reading a letter once to talk about why they wanted to be a neurosurgeon. I was like, oh, you clicked the wrong button. Next paragraph should be the 1 or 2 highlight reel of your CV. Not your entire CV written in long form. I just read your CV as the last piece of paper read before I open your personal statement. You made it this far. But the 1 or 2 highlights, if you were trying to come up with a marketing campaign of what your CV should look like, of how you want to market yourself. If I were driving by the billboard of you at, let's pretend I only drive at 60 miles per hour, what are the 1 or 2 things that you want me to know about you? And that should land in here. And then finally, what do you want to do with your in emergency medicine after you're done with residency? Knowing I won't hold you to it, but I want to know that you've given some thought to a 30 or 40 year career and not just a 3 to 4 year residency. How many applications? So I'm going to do things that should make any PD on this call really freak out. I'm going to give you actual number. So you are in one of three categories. You're either competitive, you're less competitive, you're not competitive for emergency medicine. EM's competitive. We had a 99.5% fill rate last year. Competitive, I'm going to give you numbers. PD is wholly yours. If you're now, you should know USMLE board scores from last year for matched applicants, not applied, but matched applicants was 233 and 247. So if your score is 230 or above, and understand that while there's only 1 point between 230 and 229, when you say it out loud, it sounds like a big cliff. So if your score is 230 and above, you're in the top half of your medical school class, you have honors in 50% or more of your rotations, you're competitive. Keep in mind that everything I just said goes out the window if you get a bad slow, and you won't know that. So hopefully your clerkship director will give you some guidance about what they're putting in their slow and how you did in the rotation. But you're competitive. Those people need to apply to 25 to 30 programs. If you're less competitive, if you don't fit into those categories in one or more areas, you need to apply to 35 or 40 programs. If you're not competitive, meaning you failed something, or you have some black marks or a bad slow or something like that, I will never tell you not to pursue your dream and apply to emergency medicine and send as many applications as you want. You won't get more interviews with more than 40 applications than you will with 40. It's just the law of diminishing returns. If you're not getting the 10 interviews that you need, 10 interviews, by the way, 95% chance of matching in emergency medicine. So your goal is 10. So the numbers I'm giving you of how many applications to send based on how competitive you are will yield those 10 to 15 interviews. If you apply to more 40 programs and you're just not getting 10 interviews, 100 applications won't change that. But so apply to EM, but also have a backup plan. Your backup plan should be family medicine categorical. Family medicine gives you the same training for the diverse pathology that they see, although the acuity and the pace are very different. Know that half the EDs in the country, like I said, don't hire a single board certified EM doctor, so you won't get a job as an FM doctor in an academic center or in a really competitive marketplace, but you'll be an EM doctor. And pick out a place that has an EM residency there too. Get your elective in family medicine intern year early in the ED, get a slow. No point in reapplying with the same exact application you applied the year before. You got to make it better. Get that slow in there early and reapply. But the reason why I don't tell you to apply to a prelim year or a TY year, that common terrible advice, is that if you don't match again, at least you still have a job if you're in a categorical program. Whereas if you're in a TY or a prelim year and you reapply and you don't match again, you also don't have a job. So have a pathway to moving forward to EM, even if you have to reapply all 3 years, graduate as FM doctor, and you be working. Rank list in my last 2 minutes. There's a temptation to game the rank list and try to say, well, I really love this program. It was my favorite program, but I think I have a better chance of getting in there. And they said really nice things to me. The other PD was kind of flat in their affect. I couldn't really read them. If it's your number one program, rank it number one. That's actually the definition of favorite. If you look it up in Wikipedia, wherever you look up stuff in nowadays, I don't really know. If it's your number one program, rank it number one. Even if they tell you, hey, we actually misspelled your name, we didn't mean to interview you at all, it was your favorite program, rank it number one. The matchless algorithm is entirely student driven. The math is behind it. I looked at it myself. It says that if you rank, let's say hypothetically, you rank a program number one, Austin's number two. I know, ridiculous, Austin number two, hypothetical humor. And you, in that first program, they ranked you number 20, and we love you, we ranked you number one. And that program in the match list looks like at number 20, they still have spots open, you're going there. I cannot pull you out of that program no matter how high I rank you. It's an entirely student-driven number. So when you burn yourself is when you really wanted to go someplace, but you thought you had a better chance of getting in somewhere else. You match there, and you're like, I didn't get into my top choice because I didn't list it as my top choice. Take that out and make it a wish list. That's what we do. We make a wish list. We don't try to decide who wants to come here or doesn't want to come here. We make our wish list, make your wish list, and you won't burn yourself out of your top choice. In summary, oh my God, I'm actually finishing on time. No one expected that. If you have no attention span and you're crazy, do emergency medicine. The Dean's Letter normally out October 1 this year. Dean's Letters are coming out and ARS is opening on October 21st, so everything gets pushed back a month. Do EM rotations starting with your home rotation in June, July, and August. Time to get your slows in for that deadline. Apply to 3 to 4 EM rotations per block. You'll want 2 to 3 EM slows from EM residency-based rotations, composite slows that have the most weight, and after that, educational leadership. And this year, don't feel weird about asking for individual slow, especially if you work with educational leadership. Nail your ED rotations, work hard, own your patients, get really good at SOAP presentations, and don't be a dick. And don't pad your CV. Show your values on your CV. Let that really come through so we know who you are and what you're passionate about. And we can decide if you're fit for our program. And don't game your rank list. Number one is number one. These are my happy Goombas. This is our website, and I'm guiding you this not to plug my own program. I tried very hard not to do that and keep my advice general. But what I'm trying to tell you is that if you go to our website and you click on application details, you'll see an application guide. That's the handout for this talk. So everything that I talked about is step-by-step broken down this way. So go to our website and look at it. And of course, email me if you have any questions.
We have one.
I don't know that we have time because I think we have to start the BD panel.
We have one question in the chat that I was just
Okay.
going to ask really quick, and then we can leave questions for the PD panel. But this says, how to pass-fail graded clerkships without the potential for honors? Change the advice on the number of programs you apply to.
Good question. That again is not your fault. I do fault your medical schools for that, and feel free to tell your medical schools you're putting you at a competitive disadvantage. That you shouldn't worry about that, especially this year. It's hard for me. I'm going to look for any evidence I have of where you stand in your class. Unfortunately, what it means is I'm going to have to put more weight on stupid things like your step scores. But you know, as I said, the number one driver is your slows. And if you did well on your slows and you don't have any red flags in your dean's letter, you're going to move on to the next level. So hopefully that helps. I'll take questions until you kick me off, but I think you're going to kick me off right now.
We have time for like one more question if someone has one, and then I'm going to.
And also email me, tberger@ascension.org. Please, I love mentoring students. It's one of my favorite things, and not as much as chocolate, but a close second. And do send questions. No questions are too small. If you need a mentor, if you don't, they need to be program or clerkship leadership, so that they're giving you informed advice. You don't want to take mentorship from someone who doesn't read 1,000 personal statements and tell you that your personal statement is fine. And if you feel a question that your questions aren't important enough to ask them, or even a minor question, then you have the wrong mentor. What was the question? I guess I walked through all the questions already.
Well, thank you so much.
Good luck. Don't be afraid.
I hope everyone joins us for the PD panel and the residency speed dating. I sent in the chat the link to the next thing. It's also in an email that I sent everyone. So you guys can start to transition over there and we'll get going at 2. But thank you so much, Dr. Berger. We really appreciate your time. This was so informative, and I hope everyone got out of it as much as I did.
It's a lot of information. Go to the website for the handout. Good luck, everybody. Stay safe.
Okay, Angela, I'm about to end this. I think it's the last 2 of us on here. I will see you in the other one.
Sounds good.